Hello, it's Dmitry, and I'm here to present Guyton and Hall's Pocket Physiology textbook, Chapter 76, Pituitary Hormones and Their Control by the Hypothalamus. So you can go along with your Pocket Physiology textbook for Guyton and Hall, or look at the Standard Physiology textbook. Chapter 76. The hypothalamus and pituitary gland have intimate anatomical and functional relationships. In turn, these structures regulate the function of a number of endocrine glands, including the thyroid, adrenal, and gonads. The hypothalamus and pituitary gland play an important role in the regulation of growth, metabolism, lactation, and water balance. The pituitary gland is composed of two distinct components. One, the anterior pituitary gland, or the adenohypophysis, which is derived embryologically from an upward invagination of cells from the oral cavity, Rathke's pouch, and two, the posterior pituitary gland, or the neurohypophysis, which is derived from a downgrowth of cells from the third ventricle of the brain. The pituitary gland is connected to the hypothalamus by the hypothalamic or pituitary stalk. Neurohypophysis, axons and nerve terminals, for storage of neurohypophyseal hormones. Magnocellular, a little bit tired today. At least at this time of the day, I suppose. Magnocellular neurons, whose cell bodies are located in the supraoptic and paraventricular nuclei of the hypothalamus, synthesize the neurohypophyseal hormones antidiuretic hormone, ADH, and oxytocin. Secretion granules containing these neurohormones are transported from the cell bodies in the hypothalamus down axons in the pituitary stalk to storage sites in nerve terminals located in this posterior pituitary gland. ADH and oxytocin are released from the secretion granules into the capillary plexus of the inferior hypophyseal artery, the primary blood supply to the neurohypophysis. Adenohypophysis, which is the anterior pituitary. Cells that synthesize, store, and secrete adenohypophyseal hormones. 5 cells in the anterior pituitary gland synthesize, store, and secrete 6 polypeptide or peptide adenohypophyseal hormones. One hormone, prolactin, acts on the breast. The other 5 are tropic hormones that stimulate secretion of hormones by other endocrine glands. So sort of like a multi-part thing. Or, in the case of growth hormone, the liver and the other tissues. One cell type, the gonadotrope, secretes 2 hormones, follicle-stimulating hormone, FSH, and luteinizing hormone, LH. The cells that secrete the anterior pituitary hormones and the chemical structure and physiological actions of the adenohypophyseal hormones are listed in Table 76.1. And you can see it right here. They prefer tables, I guess, in this context. So let's just go down the list, okay? Adenohypophyseal cells and hormones. So the cell... These are in the anterior pituitary, right? So corticotropes, they release adrenocorticotropic hormone, also called corticotropin, which I think you should also call ACTH as well. Chemistry, it's a single chain of 39 amino acids. Physiological action stimulates production of glucocorticoids and androgens by the adrenal cortex. And I think specifically when we talk about corticotropes, they're talking about glucocorticoids, so that would be... adrenal cortex, that's fine. I'm trying to think about the different zones, but they might go into that. Maintains the size of the zona fasciculata and the zona reticularis of the cortex. So they're saying basically they act at the fasciculata and the reticularis respectively. Now, fasciculata, if I'm not mistaken, it's glomerulosa, fasciculata, and reticularis. Reticularis is where the androgens are being made. Those are where the sex hormones are being made. And the fasciculata, I believe that's where glucocorticoids are being made. That's where it's basically mineralocorticoids in the glomerulosa, the glucocorticoids in the fasciculata, and then the sex hormones in the reticularis of the cortex. So we'll go down to the next one. Thyrotropes. So thyroid stimulating hormone, thyrotropin, also called TSH. So basically, thyrotropes release, TRH. Wait, no, is that? Thyrotropes produce TSH. Yes, TSH. So basically what's happening is that the TRH, or the thyroid releasing hormone, or thyrotropin releasing hormone, from the hypothalamus goes down to the pituitary stalk, down to the thyrotropes, and then releases TSH from there. So TSH, it's a glycoprotein of two subunits, an alpha, 89 amino acids, and a beta, 112 amino acids. TSH stimulates the production of thyroid hormones, T3 and T4, right, by thyroid follicular cells in the thyroid, maintains the size of the follicular cells. And when it says maintains the size of the follicular cells, all that's really saying is that that's where it's acting on. Because what happens is if a hormone is not acting on a particular endocrine organ, it atrophies, right? So let's say, for example, if we don't produce enough TSH, your thyroid will atrophy. If you don't produce enough if you don't produce enough ACTH, well, then those zones of the cortex, adrenal cortex, will atrophy, right? Because it has to have stimulation for it to maintain its size. And so that should give you a hint when something is atrophying. That's a consequence of the hormones that are acting on it are limited for some reason potentially. That's one of the possible situations in that case of atrophy. That's not being active for some reason. Anyway, next one. Gonadotropes. Gonadotropes, FSH, follicle stimulating hormone, glycoprotein of two subunits, alpha, 89 amino acids, and beta, 112 amino acids. If you don't forget, that's the exact same setup of alpha and beta subunits in terms of the actual number of amino acids as the thyrotropes were, the TSH. And it says here, so for FSH, stimulates the development of ovarian follicles, regulates spermatogenesis in testes. True. FSH is going to be involved, if I'm not mistaken, in both men and women, but it's specifically, I'm trying to remember, I have a couple diagrams on this, but specifically FSH is going to promote the production of estrogen or estrogenic hormones by promoting the production of aromatase. And it does promote these other things downstream of that, essentially. At least to some extent. Now, luteinizing hormone, but that's the main thing, is that it promotes estrogen production. Now, luteinizing hormone is kind of the inverse of that. Or you could say the opposite end of that spectrum. The complementary hormone, you could say, is more accurate to say. So luteinizing hormone, LH, is a glycoprotein of two subunits, an alpha subunit of 89 amino acids and a beta subunit of 115 amino acids. Again, sort of similar to these previous two, except there is a few more amino acids on the beta subunit for LH. Now, LH causes ovulation and formation of the corpus luteum in the ovary, stimulates production of estrogen and progesterone by the ovary, stimulates testosterone production by the testis. This is true, but in a kind of a roundabout way. Yes, does LH promote estrogen production? Yes, but that's because what happens is that androgens are going to be converted into estrogens via aromatase. And aromatase is being produced by the influence of FSH. So basically, LH goes to, I believe, I don't need to go into the specifics of this, to be honest with you, but you can look into it more. Basically, LH promotes androgens like testosterone or androstenedione, and those are converted via aromatase into estrogens, like estradiol, for example. And that aromatase is being made under the influence of FSH. So they're kind of interconnected in that sense. Anyway, we will continue. Adenohypophyseal cells and hormones continued. Cell, hormone, chemistry, physiological actions. Okay. Mammotropes, also called lactotropes. They produce prolactin. Chemistry, single chain of 198 amino acids. Stimulates milk secretion and production. And then you also have somatotropes, which produce growth hormone, which is a single chain of 191 amino acids. And that stimulates body growth, stimulates secretion of insulin-like growth factor, IGF-1, stimulates lipolysis, fat breakdown, inhibits actions of insulin on the carbohydrate and lipid metabolism. Now, I want to make a couple comments about that in particular. When it talks about, it stimulates the secretion of IGF-1, it's important to know. Let me see that. Let me continue with this. And lipid metabolism. Okay. So what I wanted to say about IGF-1 is that is the key intermediate molecule. That's the key mediator of growth hormone's effect. So if IGF-1 doesn't exist for some reason, if it's somehow deficient, your body can't produce it or your body doesn't respond to it correctly, then the effect of growth hormone is going to be almost zilch. It's largely acting through IGF-1. That is the key mediator of that action of growth hormone. Just for like an FYI. And also another FYI, just as a summary for everything, for the posterior pituitary, the hormones are being made in the hypothalamus, not in the neurohypothesis itself, not in the posterior pituitary itself. It just releases them. And that is going to be the ADH and the oxytocin. For the adenohypophysis, the anterior pituitary, they are being made natively, but under the influence of hormones from the hypothalamus itself. And that can be, and just a way to remember the anterior pituitary is that it spells flat pig, so or without the I, admittedly. So FSH, F, LH, L, ACTH, A, TSH, T, right? Prolactin, P, and growth hormone, G. Just as a way to remember which hormones are from what, that's one way to remember. FLAT, PG, for anterior pituitary. There is considerable similarity in the chemical structures of the glycoprotein hormones, thyroid-stimulating hormone, FSH, and LH, all of which are secreted from the basophilic cells. Similarly, there is structural homology between the prolactin and the growth hormone, both of which are secreted from the acidophilic cells. The corticotropes synthesize a pre-pro hormone containing the amino acid sequences for adrenocorticotropic hormone, ACTH, and melanocyte-stimulating hormone, MSH. In humans, ACTH is generated in the anterior pituitary, but no appreciable amount of MSHs, or these melanocyte-stimulating hormones, are secreted under normal conditions. Although the administration of MSH in humans causes darkening of the skin by increasing synthesis of the black pigment melanin, it is likely that the pigmentary changes in endocrinological disease are due primarily to changes in the circulating ACTH because ACTH has MSH activity. And that's an important thing to note. I'm gonna go look at something briefly just to confirm I'm not confusing two different conditions right now. But I would like to say, let me just make sure I'm confirming I'm not going to mix these two things up. Yes, Addison's disease. So Addison's disease, what happens is you have darkened skin. And I think one of the Kennedys had this, if I'm not mistaken. You have a darkened skin tone as a consequence of this hormonal imbalance. Let me just make sure if I'm getting the causes correctly as well. I want to make sure I'm not confusing with something else. It is an autoimmune reaction where there's immune system attacks on adrenal glands. Okay, so because there's an autoimmune reaction to the adrenal glands, that's going to prevents the body from making cortisol, aldosterone, so forth. Yeah, but the consequences long term are going to be, yes, you can have these sorts of darkening effects on the skin. Anyways, that's just an aside. Hypothalamus controls pituitary secretion. Blood supply to the anterior pituitary gland. Hypothalamic hypophyseal portal vessels. An extensive network of capillary sinuses surrounds the anterior pituitary cells. Most of the blood entering these sinuses has first passed through another capillary plexus in the lower hypothalamus or median eminence. The blood from the latter capillary plexus comes from the superior hypophyseal artery and flows through the hypothalamic hypophyseal portal vessels of the pituitary stalk to bathe the adenohypophyseal cells. hypophysiotropic hormones, releasing and inhibiting hormones, secretion of anterior pituitary hormones. In addition to the hypothalamic neuroendocrine cells, which synthesize neurohypophyseal hormones, other neurons in discrete areas of the hypothalamus synthesize the hypophysiotropic neurohormones, releasing and inhibiting hormones, which control secretion of the anterior pituitary hormones. Although the axons from the magnocellular neurons of the supraoptic and paraventricular nuclei terminate in the posterior pituitary gland, the nerve fibers from the hypothalamic cell bodies that synthesize the hypophysiotropic hormones lead to the median eminence. Here, the releasing and inhibiting hormones are stored in secretion granules in the nerve terminals. On the stimulation of these hypothalamic neuroendocrine cells, these neurohormones are released into the capillary plexus of the median eminence, flow through the hypothalamic hypophyseal portal vessels, and reach the sinusoids through the adenohypophyseal cells. The anterior pituitary cells respond to the hypophysiotropic hormones by either increasing or decreasing the synthesis and secretion of adenohypophyseal hormones. It is largely stimulatory for reference, but there is a counterexample of dopamine. Dopamine inhibits the production of prolactin. That is one of the exceptions where it's actually an inhibitory factor. But most of these hormones from the hypothalamus are in fact stimulatory. The 6 established hypophysiotropic hormones are listed in Table 76.2. Releasing hormones are most important for secretion of most adenohypophyseal hormones, whereas an inhibitory hormone is most dominant in the control of prolactin secretion. Note that growth hormone secretion is influenced by both a releasing and an inhibiting hormone, and a single hypophysiotropic hormone, gonadotropin-releasing hormone, stimulates the gonadotropes to secrete both the FSH and the LH. All hypophysiotropic hormones are peptides, polypeptides, or derivatives of the amino acid tyrosine. So we'll get into that soon, I think. The hypothalamus receives neural inputs from many areas of the brain. This information, which is related to the well-being of the body, is integrated into the hypothalamus and has an impact on endocrine function in large part by the influence of the hypophysiotropic hormones on secretion of the anterior pituitary hormones. In turn, the tropic hormones from the anterior pituitary gland stimulate target endocrine glands and tissues. The resultant changes in target gland hormones and metabolic substrates in the peripheral blood exert negative feedback control on the secretion of anterior pituitary hormones through a direct effect on the adenohypophyseal cells and through an indirect action at the level of the hypothalamus to alter the release of hypophysiotropic hormones. Okay. Now, let me go read through this right now. So here's the table 76.2, hypophysiotropic hormones. So they're talking about, I think, hormones of the hypothalamus. So thyrotropin-releasing hormone, or TRH. What does that encourage? It's a peptide of 3 amino acids. Fair enough. Okay. What does it do? It stimulates secretion of TSH by thyrotropes. True. So basically, TRH goes to the thyrotrope and encourages TSH production. Secretion. Gonadotropin-releasing hormone does 2 different things. It says single chain of 10 amino acids, and it stimulates the secretion of FSH and LH by the gonadotropes. Corticotropin-releasing hormone. And I just want to say again, thyrotropin-releasing hormone, TRH. Gonadotropin-releasing hormone, GnRH. Like a G, capital G, little n, RH. Corticotropin-releasing hormone, CRH. Now, growth hormone-releasing hormone, GHRH. Well, let me not skip anything. So CRH, corticotropin-releasing hormone, single chain of 41 amino acids, stimulates secretion of ACTH by corticotropes. So true. Growth hormone-releasing hormone, single chain of 44 amino acids, stimulates secretion of growth hormone by somatotropes. And now growth hormone inhibiting hormone, also called somatostatin. And there's also, by the way, drugs that mimic this as well. Anyway, single chain of 14 amino acids, inhibits secretion of growth hormone by somatotropes. And again, there are molecules that resemble the somatostatin, and I want to make sure they're not confusing these with something else. So let me just make sure that I'm looking this up correctly. So I'll just confirm right now. Yes, yeah. Octreotide is what I wanted to confirm. So octreotide is an example of a molecule that mimics is a synthetic somatostatin analog, and it mimics basically GHIH somatostatin, and that's going to inhibit growth hormone. And so if you have a situation where, let's say, for example, you have acromegaly, or I guess if you have gigantism, but realistically speaking, if you have something like acromegaly, somatostatin analog like octreotide can be used to treat that. Now, going on to prolactin inhibiting hormone. It goes by another name, dopamine. This inhibits secretion of prolactin by lactotropes, and that's the most clear-cut example of an actual inhibitory hormone coming from, or you could say, in this case, inhibitory specifically, you could say peptide or polypeptide coming from the hypothalamus. That's very clearly the only real purpose it's there for, is to inhibit something. There are other hormones coming from the hypothalamus that influence the production, the secretion, or inhibition of other hormones that you might not necessarily expect, but it's not as relevant as I would say somatostatin is the other one. Somatostatin and PIH, those are the two big ones. If you want to know about which hormones from the hypothalamus are inhibitory, it's growth hormone inhibiting hormone, somatostatin. It's pretty straightforward. And also the prolactin inhibiting hormone, better known as dopamine. And likewise, like the fact there's octreotide for to mimic somatostatin, there's also things like bromocriptine, which are intended to inhibit. There's other ones as well, but bromocriptine is an example of a analog or something that mimics dopamine in order to have some of those same kind of effects. Anyway, let's go on. Physiologic functions of growth hormone. Multiple physiological effects of growth hormone. In contrast to the other pituitary hormones, which stimulate the specific target glands, growth hormone has multiple effects throughout the body. Promotion of linear growth. Growth hormone stimulates the epiphyseal cartilage or growth plates of the long bones. Under the influence of growth hormone, the chondrocytes in the growth plate are stimulated, leading to I don't know how I can say hypophyseal so easily, but I can't say proliferation. So, not so well, I suppose. Let me go back to this. Okay. There we go. So, where do I start? Under the influence of growth hormone, the chondrocytes in the growth plate are stimulated, leading to proliferation of these cells and deposition of new cartilage, followed by conversion of this cartilage to bone. This process elongates the shaft of the long bones. By late adolescence, when there is no remaining epiphyseal cartilage and the shafts have fused with the epiphyseal closure, growth hormone can no longer cause lengthening of the long bones. Because growth hormone also stimulates osteoblasts, which deposit new bone, bones thicken and total bone mass is increased by growth hormone even after epiphyseal closure. Very true. Promotion of protein deposition in tissues. Growth hormone is a protein anabolic hormone and produces a positive nitrogen balance. It increases amino acid uptake in most cells and the synthesis of amino acids in proteins. And I want to see if it goes into it or not. I don't think it does, but back into the whole point that, even after the fact, growth hormone is still having an impact after your bones close. But it won't, after the closure, it will not cause you to grow any taller. That's why there's a different pathological presentation for high growth hormone excess in children versus in adults. So let's say, for example, you have a man in his 30s and he has really, really high growth hormone levels for some reason. He will have acromegaly, right? He will have very prominent features and issues with his joints because he's producing way too much growth hormone and that's messing with his joints and stuff like that. Now, if he was instead a 10-year-old, or let's say an 8-year-old or something like that, and the bones have not closed yet, he will not have acromegaly, quote unquote. He will have gigantism. His body will be elongating his bones in a way that's really kind of excessive and inappropriate. Because in this case, those have not closed yet. The bones have not closed yet. So that kind of growth can still happen. Anyway. Promotion of fat utilization for energy. Growth hormone causes the mobilization of fatty acids from the adipose tissue and the preferential utilization of free fatty acids for energy. This action of growth hormone, together with its protein anabolic effects, produces an increase in lean body mass. The lipolytic effects of growth hormone require several hours to occur. At least part of this effect is due to the actions of growth hormone to impair glucose uptake into the adipose cells. Because growth hormone increases plasma levels of free fatty acids and keto acids, it is ketogenic. And if I'm not mistaken, it also encourages insulin resistance, but you would have to go confirm that, I would say. Impairment of carbohydrate utilization for energy. Growth hormone decreases the uptake of and utilization of glucose by many insulin-sensitive cells, such as muscle and adipose tissue. As a result, blood glucose concentrations tend to rise and insulin secretion increases to compensate for the growth hormone-induced insulin resistance. Thus, growth hormone is diabetogenic. So basically, I just gave it away. Yeah, so it does encourage insulin resistance because it's going to produce this environment where you need more insulin in the body to take up more of the stuff that it's producing. It's going to increase blood glucose concentration. It is going to increase, by the way, of course, free fatty acids. But more importantly, in this context, you're going to have more glucose in the blood, and so you're going to have more insulin released to sort of respond to that. And so it is diabetogenic as well. Now, somatomedins and anabolic effects of growth hormone. The effects of growth hormone on linear growth and protein metabolism are not direct, but they are indirectly mediated via the generation of polypeptides called somatomedins or insulin-like growth factor, IGFs. Somatomedins are secreted by the liver and other tissues. Somatomedin C, or IGF-1, is a circulating 70 amino acid peptide produced by the liver that reflects plasma GH levels. The growth-promoting effects of growth hormone, however, are due to locally produced and circulating somatomedins in cartilage and muscle. Locally produced somatomedins act in an autocrine or paracrine fashion to stimulate growth. Growth hormone secretion, metabolic stimuli. Growth hormone is under the influence of both a hypothalamic releasing GHRH hormone and a hypothalamic inhibiting hormone, somatostatin. Feedback regulation of growth hormone secretion is mediated primarily by circulating IGF-1 via actions at both the hypothalamus and the pituitary. High plasma levels of somatomedin C, again IGF-1, decrease GH release by increasing the secretion of somatostatin from the hypothalamus and acting directly on the pituitary to decrease the responsiveness to GHRH. Growth hormone secretion is highest during puberty and decreases in adult life. This decrease in adult life may be partially responsible for the decline in lean body mass and increase in adipose mass that are characteristic of senescence. 3 general categories of stimuli increase growth hormone secretion: fasting, chronic protein deprivation, or other conditions in which there is an acute fall in plasma levels of metabolic substrates such as glucose and free fatty acids, increased plasma levels of amino acids such as occurring after a protein meal, exercise and stressful stimuli such as pain and fever. Clearly, the increase in growth hormone during fasting would be beneficial because growth hormone enhances lipolysis and decreases peripheral utilization of glucose. After a protein meal, increased plasma levels of growth hormone would favor the utilization of amino acids for protein synthesis. Yeah, so that's an important thing, is that growth hormone is going to be increased both in the context of low glucose levels, like a caloric restriction situation, but also when you have high amino acids. And it's it's mainly really like an anabolic or pro-growth pathway for the most part. Barring the whole, making sure there's enough glucose and fat in the serum. Okay. Abnormalities of growth hormone, secretion and their impact on on the skeletal system. The importance of growth hormone in linear growth is reflected by the clinical states associated with the deficiency or excess secretion of growth hormone before epiphyseal closure. Apparently everything that I was talking about before is going to be covered in this chapter, so it's a little bit redundant, I suppose, my commentary here and there. Short stature, dwarfism, occurs when pituitary secretion of growth hormone is deficient. In comparison, children grow taller, gigantism, when tumors of the somatotropes of the anterior pituitary secrete large amounts of growth hormone. If a pituitary tumor secreting growth hormone appears after epiphyseal closure, the adult form of the disease occurs. With acromegaly, linear growth is normal, but there is enlargement of the hands and feet, protrusion of the lower jaw, prognathism, and overgrowth of the facial bones. In addition, virtually all internal organs are of increased size. And that's an example too. When you have people, for example, who abuse growth hormone because they want to make gains in their muscles, they can get like a kind of a big gut because they have all their organs expanding as well. So just something to be aware of when people talk about taking different kinds of hormones and stuff like that to kind of make some sort of gains or something like that. Just be aware that it does have some negative consequences or externalities that are not exactly desirable, as in, your abdomen is going to be a bit protuberant potentially. The anti-insulin effects of growth hormone may ultimately lead to diabetes mellitus in states of chronic growth hormone excess. True. So again, in addition, virtually all internal organs are of increased size, and yes, it can lead to diabetes mellitus if it maintains sort of this growth hormone excess. Very important to be aware of. And that's something that's not really focused on when we talk about acromegaly, because acromegaly, they're always talking about, the jaw looks ridiculous, the feet and the hands, but it's also, yes, there's also going to be these effects on the possibility of getting diabetes or something like that. That's important too. Now, the posterior pituitary gland and its relation to the hypothalamus. The neurohypophyseal hormones ADH and oxytocin are synthesized as pre-pro hormones in the cell bodies of magnocellular neurons located in the supraoptic and paraventricular nuclei. They are then transported in the secretion granules down axons to nerves terminals in the posterior pituitary gland. ADH is synthesized largely in the supraoptic nucleus, and the oxytocin is synthesized largely in the paraventricular nucleus. And there's not a perfect mnemonic for that. You just have to remember that, ADH, supraoptic, oxytocin, paraventricular. Okay, so I always remember it as SAPO, or I guess SAPO or SAPO or whatever you want to say, but it's not a real word. You just need to know that supraoptic, i.e. ADH producing, paraventricular, i.e. oxytocin producing. That's all you really need to know. Although it's not as black and white, not as clear cut, but that's the gist of it essentially. So let's go back down to it. Yeah, and although each hormone is synthesized in the alternate site, that's true. The secretion of granules containing either ADH or oxytocin also contain an additional protein, or neurophysin, that is part of the pre-pro hormone. When a nerve impulse travels from the cell body of the magnocellular neurons down the axon to the nerve terminal, both the neurohormone and the corresponding neurophysin are released from the secretion granules into the capillary blood as separate polypeptides. ADH and oxytocin are non-peptides with a similar chemical structure. Only the amino acids in positions 3 and 8 differ. So they're very similar, despite obviously having different physiological effects in the body. Physiological functions of antidiuretic hormone. ADH, or antidiuretic hormone, regulates the osmolality of the body fluids by altering renal excretion of water. Well, this chapter is a lot more comprehensive than I thought. I didn't know this. I know a lot of the information in this chapter. I just didn't know that this chapter was this in depth for certain things. So ADH plays an important role in the regulation of plasma osmolality. As discussed in chapters 28 and 29, in the absence of ADH, the collecting tubules and collecting ducts are largely impermeable to water, which prevents significant reabsorption of water in this portion of the nephron, thus resulting in large volume of dilute urine and a net loss of water. Consequently, the osmolality of body fluids rises in comparison when increased ADH activates V2 receptors on the basolateral membrane of the tubules via a cyclic adenosine monophosphate, cyclic AMP, second messenger system. Cytoplasmic vesicles containing water channels, aquaporins, are inserted into the apical membrane. This increase in the permeability of the tubules to water, therefore, water moves by osmosis from the tubular to the peritubular capillary fluid. In the collecting ducts, the urine becomes concentrated and its volume decreases. As a result, there is a retention of water in excess of solute, and the osmolality of body fluids decreases. Now, this is a lot more interesting than they might present, but basically, a lot of the things that are encouraging water retention in your kidneys are going to also encourage sodium retention. So basically, your body will be taking in sodium of these different sorts of transporters and symporters, whatever it might be, under the influence of other hormones or under the influence of drugs. And this is going to be done by taking in sodium, and then the water follows the sodium into the body. Now, this is a very interesting exception to that rule. ADH uses a aquaporin 2 transporter to encourage water to simply go into the body as free water, not as a water being brought in because of the sodium concentration, because you're bringing in sodium and the water is going to follow it. No. This is because of a free water absorption at the collecting duct via aquaporin 2. Very interesting. And that's, by the way, why you can have, when you have ADH excess, or let's say you have SIADH, one of those two things, you can have issues with your sodium levels, because precisely this is free water. And this is not sodium mediated. This is free water absorption. Very important. In accordance with its role in the regulation of the osmotic pressure of plasma, ADH secretion is sensitive to small changes in plasma osmolality, approximately 1%. When plasma osmolality increases above normal, the rate of discharge of ADH secreting neurons in the supraoptic and paraventricular nuclei increases, and ADH is secreted from the posterior pituitary gland into the systemic circulation. Circulating ADH increases the permeability of the collecting ducts to water, which ultimately decreases plasma osmolality to normal levels. The opposite changes in neuronal discharge and ADH secretion occur when plasma osmolality declines. ADH secretion is regulated by osmoreceptors in the anterior hypothalamus that send nervous signals to the supraoptic and paraventricular nuclei. Osmoreceptors are outside the blood-brain barrier and appear to be located in the circumventricular organs, primarily the organum vasculosum, so the organum vasculosum of the lateral terminalis. These same osmoreceptors may also mediate the thirst response to increase plasma osmolality. ADH secretion is influenced by multiple factors. Other than increased plasma osmolality, stimuli that increase ADH secretion include hypovolemia, hypotension, nausea, pain, stress, and a number of drugs including morphine, nicotine, and barbiturates. So factors that increase ADH secretion include hypervolemia, hypertension, and alcohol. The influence of these factors on neurons in the supraoptic and paraventricular nuclei that secrete ADH may have an impact on the regulation of body fluid osmolality. For example, in hypovolemic states, elevated plasma levels of ADH may decrease plasma osmolality. ADH contributes to the maintenance of blood pressure during hypovolemia. Stimulation of ADH secretion by hypovolemia and or hypertension is achieved by the reflexes initiated from receptors in both the high and low pressure regions of the circulation. The high pressure receptors are those in the carotid sinus and aortic arch. The low pressure receptors are those in the cardiopulmonary circulation, especially in the atria. At least a 5% decrease in blood volume is necessary to increase ADH secretion appreciably by this reflex mechanism. Greater degrees of hypovolemia and hypotension can result in very strange increases in plasma ADH concentration to the levels much higher than those required to achieve maximal antidiuresis. When these unusually high plasma levels of ADH occur, such as during hypotensive hemorrhage, ADH constricts vascular smooth muscle and helps restore blood pressure to normal levels. This action of ADH is a result of the peptide binding to vascular V1 receptors on arteriolar smooth muscle. The vasoconstriction induced by ADH is mediated by calcium and phospholipase C generated second messengers. Physiological functions of oxytocin. Oxytocin plays an important role in lactation by causing milk ejection. Oxytocin causes contraction of the myoepithelial cells of the alveoli of the mammary glands, which forces milk from the alveoli into the ducts so the baby can obtain it by suckling. The milk ejection reflex is initiated by receptors on the nipples of the breast. Suckling causes the reflex stimulation of oxytocin-containing neuroendocrine cells in the supraoptic and paraventricular nuclei and secretion of the oxytocin from the posterior pituitary gland. The circulating oxytocin then causes the myoepithelial cells to contract, initiating milk ejection. Oxytocin contributes to parturition. Oxytocin also causes contraction of the smooth muscles of the uterus. The sensitivity of this response is enhanced by plasma levels of estrogen, which increases during pregnancy. During labor, the descent of the fetus through the birth canal stimulates receptors on the cervix, which send signals to the supraoptic and paraventricular nuclei and cause secretion of oxytocin. Secretion of oxytocin, in the turn, contributes to labor by causing contraction of the uterus. And that ends Chapter 76 of Guyton and Hall's Physiology. If you stuck the whole way, well, thank you very much for listening, and have a great rest of your day. Bye.